Good morning and welcome back to the third and final session of the Minimizing Risk training, where we hope to help providers meet licensing requirements related to risk, specifically regulations 160C, 520C, and 520D, and beyond. This is a joint training of the Office of Licensing and the Office of Clinical Quality Management. This three-part series has been designed such that each session has built off the previous session. This is especially important if your organization was previously found non-compliant with any of the regulations that we've been covering over the past 3 days of training.
Britt, somehow you are muted. There you go.
Sorry about that. We thank you for being here. We know you're very busy and we appreciate you taking time out of your busy schedules to attend the sessions. To make sure you get all future announcements from the Office of Licensing, including training and other notices, please subscribe to the free email list. The link for the Office of Licensing's webpage is provided on the slide. At that link, you will simply click the subscribe to the email list button indicated under the blue arrow on this slide. Today, you will hear from several presenters from the Office of Licensing. Your presenters will be Mackenzie Glasgow, Associate Director of Quality and Compliance, Michelle Laird, Manager of the Incident Management Unit, and Larissa Terwilliger, Training Coordinator. From the Office of Clinical Quality Management, your presenters will be Mary Beth Cox, Quality Improvement Coordinator, and me, Britt Welch, Director of the Office of Community Quality Management. Our two offices came together to develop this training, and we look forward to partnering for future trainings. As in the previous two sessions, I wish to thank the different groups and colleagues that devoted numerous hours to producing this training. Those folks include the Region 5 Quality Council members, the members of the Risk Management Review Committee, providers, CSBs, and licensing specialists who served as key informants on the regs and testers of the tools you will be introduced to. And we thank our colleagues from the Office of Community Quality Improvement, the Office of Clinical Quality Management, the Office of Integrated Health, and the Office of Licensing. To go over a few housekeeping items, please put all your comments and questions in the Q&A feature by clicking on the Q&A icon on your screen. Again, please use the Q&A feature for your questions and comments. Please note, we will try to answer some questions during today's session. However, we do have a time limit for the session, and we want to ensure everybody sees the answers. So most questions will be included in the FAQ, which will be distributed after today's session. Again, after today's session, a FAQ will be produced and distributed. The slides and documents will be posted on the licensing website. What do you say we get started? The purpose of the 3-day training series has been to provide you with information, tools, and resources that can assist you in achieving compliance with regulations 160C, 520C, and 520D, along with the related skills and tasks that need to be completed. Now, as you're aware, these 3 regulations focus on tracking serious incidents and conducting a systemic risk assessment review. In session 1, we focused on the systemic risk assessment. In session 2, we focused on tracking serious incidents, including the at-a-glance flowchart, serious incident definitions, reporting and care concern criteria, the Delta application, that's the web-based portal to ensure privacy and protection of health records, CRIS reporting, care concern thresholds and the role of the incident management unit, provider responsibilities, contacts and resources, root cause analysis, the RCA template, root cause analysis policies and procedures, and issues observed by the Office of Licensing. We also discussed basic data terms, basic risks and conditions. We had a demonstration of the risk tracking tool and a homework assignment. Session 1 serves as the foundation for session 2, and session 2 serves as the foundation for what we will be covering today. And I will remind you of what I said at the start of the training series, and that is you can do this. So session 1, as I said, focused on the systemic risk assessment. Session 2 on tracking serious incidents. Today, We pull it all together and we lay the groundwork for taking it further. I do want to remind y'all that there will be a post-training survey after this session, like the previous 2 sessions. Please take time to do the post-test survey today. We're allowing time during the session to do it, and it helps us know where we need to make improvements. Okay, let's take a look at the homework experience and what that was like for y'all. Now, the assignment was to either begin or to update your tracking of serious incidents and care concerns. A couple of questions for you. Did you use the new Excel risk tracking tool? If yes, how did that work for you? Or did you update the tool or method you use? Now, last time y'all did a wonderful job of sharing your homework experience. If we could get a few people willing to do that again, that would be great. If you would just click on the raised hand icon to discuss your experience. My teammate, Mary Beth Cox, will select a few participants so we can learn about your experience.
All right, so I'm looking in the participant list. And there were a few people who had their hands raised before this slide, so I'm not sure if they mean to have them still raised right now. But we had Amanda Donaldson raised her hand. So Amanda, I'm going to press the feature to allow you to talk, and you should be able to unmute so you can share with us.
Good morning. Can you hear me?
Yes, we can hear you.
So I really liked the Excel sheet that you guys had provided. I have one that I've been using, really kind of similar, but I liked how you had it self-populating over to the other pages. And so I'm actually working on right now transferring everything that I already have in my tracker for this year into that new system. But what I also found really, really helpful was the risk, the root cause analysis and serious tracking template you guys gave. And so I actually was starting to use that this morning on a serious incident and switching over to just using those, that template instead of the one that we have. And so, yeah, that's kind of how I've been using it. Again, I really liked the that one tracking tool for the root cause analysis. I think it's going to make sure that I'm hitting all the points that I need to be hitting as the risk manager for our company.
Thank you, Amanda. That is great feedback and sharing a great experience of what you've done in just 1 week. So yeah, thank you so much.
Yep.
Okay, I'm going to put you back on mute. Again, no offense. Let's see, we still have, we have another person who's raised his hand. All right, so Michael, I'm going to allow you to talk, and you should be able to unmute and tell us about your homework. There you go. Hi.
Hi.
Good morning.
Good morning.
So how did your homework go?
It went great. That monthly tracking sheet, that monthly tracking Excel sheet turned out to be beneficial. I had actually already created an incident report tracking log by the month.
Okay.
And I just had to input a formula to transfer all that into the template you guys created.
Oh, great. Okay.
I mean, of course, I did have to put in some factors besides your care concerns.
Okay. All right. So you use the add your own to add your own risks and conditions in there?
Yes, and I also made some modifications because not only are we assessing our incidents by the incidents themselves, but we're assessing them by which program or service it happened in.
Mm-hmm.
Because we have like multiple services with our agency.
Right. All right. Well, that's great to hear that you were able to use that and start transferring your data over, and you found it helpful.
Mm-hmm.
Thank you, Michael.
You're welcome.
Okay. All right, well, I am not sure. I think the other two people who had their hands raised have had their hands raised before this slide. So we had two sharers, and I think we can keep moving. That's okay. Brett?
Absolutely. Amanda and Michael, thank y'all for sharing. Great work. Greatly appreciate y'all doing that for us. Let's move on and talk about our learning objectives for today. As I noted, today we pull all the sessions together, and today's objectives for you are to experience a demonstration of reviewing serious incidents at the individual level, quarterly and annually, experience a demonstration of the new templates and tools that have been shared with you, understand how to begin doing a risk assessment if you have not started yet, understand common questions and answers, understand how to take it further after identifying risk in your systemic risk assessment review. So without any further delay, I will hand the training off to my teammate, Mary Beth Cox. And again, we greatly appreciate your participation today. Mary Beth?
Okay, so the first part of today's training, like Britt said, is going to be walking through an example. So this is with a fictional provider, Acme Residential Services. Yes, it's like the cartoon. And as we go through it, just keep in mind this is fictional. The data that I'll be showing is also fictional. So just bear with us, bear with me. If you don't find it quite realistic, that might be just a byproduct of it being fictional. So Acme Residential is a group home provider with 8 houses that have 4 beds each. They can serve a maximum of 32 individuals. We're going to observe as Acme Residential reviews an individual incident, does a root cause analysis, does their quarterly and annual review of serious incidents and care concerns, and conducts their annual systemic risk assessment. We'll also see how they take it further by creating measurable goals and objectives. And I'm going to go off camera so I'm not distracting anybody. All right. So as you all hopefully recall, this is the at-a-glance flowchart for incident reviews that we've reviewed in depth in the previous 2 sessions. The flowchart walks through how to review serious incidents, starting at the individual level, then going through the quarterly and annual review. For detailed explanation of this flowchart, you can read through it closely or watch a recording of the previous sessions, which will be available hopefully in the next few weeks after this training. We're going to start our example with an individual event as indicated by the red arrow on this slide. So this is a description of our individual serious incident event. So what happened? This was a level 2 serious incident report event. It is for John Harvey. He is a 42-year-old male with cerebral palsy. He typically uses a walker to get around, but not while going up and down stairs. On March 31st, 2023, he fell backwards while walking up the brick steps to the front of the home. He hit his head and was bleeding but conscious. 911 was called and John was transported via ambulance to Acme Hospital. He received 10 stitches and was released. One question that Acme Residential also asked is it a care concern? And yes, it is a care concern because John had an emergency room visit for a seizure 2 months ago. So let's look at Acme Residential's responsibilities here. They have to collect information about the incident and report the level 2 incident in CRIS within 24 hours per regulation 160D2. They have to conduct a root cause analysis or RCA for the level 2 incident within 30 days of discovery per 160E. They need to review the care concern and they need to collect the data in order to include it with their quarterly review, 160C, and annual review for 520C and 520D since it is a care concern. So actually, before we go further, I have a poll question for you guys. Let me get it up and running. So the question before we go further is, what tools would you use in this example if this was something that happened in your agency? So you can check all that apply here. So let's see, we have, all right, guys, we have 627 people logged on to the call. And I'm probably gonna stop it around, let's see, can we get to 300 or maybe even 400? Okay, we are at about almost at 350, and for the sake of time, I'm going to end the poll and I'm going to share the results. So you should be able to see the results now. And we had almost 100% using the serious incident review and root cause analysis template. About 75% would reference the handout about risk triggers, thresholds, and care concerns. And about 72% would use the Excel risk tracking tool, and a little more than half would use the systemic risk assessment template. Great. So this wasn't really a test question. This was just kind of to get you thinking about the tools that we've been using and which ones you would use in this instance. So let me close that and get my slides back up. And it was a bit of a trick question because in this example, we're going to look at all of those tools and how you would use them. So let's look at this. Let's look at how Acme did a root cause analysis for this incident using the 5 whys. Remember, this is a fictional provider for illustration purposes only. I think by now, many of you are familiar with the 5 whys. But it is a root cause analysis technique where you describe the problem and then ask why sequentially to determine the ultimate reason why or the root cause. So this training wasn't designed to go into depth about doing a root cause analysis, but there are tools and resources on the licensing website and also my office's website, the Office of Clinical Quality Management, that will be included on the resources page at the end of the slides for today's training. So let's walk through how we use the 5 whys here, but we're going to start with the licensing requirement of giving a detailed description of what happened. So this is 160E1A. So we talked about it before, but I'm just going to read through it again. We have a little more detail here. On March 1st, John Harvey fell backwards while walking up the brick steps to the front of the house. He does not use his walker while on the steps. He was using the left side handrail, but he lost his balance after his right foot got caught on a step. He fell down 2 steps and hit his head on the wall and was bleeding. He was still conscious. 911 was called. He was transported to the hospital and received 10 stitches and released. So the next licensing requirement is to do an analysis of what happened. So this is 160E1B. So here, Acme chose to use the 5 whys. You're not required to use the 5 whys. This is what they chose to do. And let's walk through their 5 whys. So they start by asking, why did John fall while walking up the steps? Because he was using the left side handrail for balance, but lost his balance on the right side after his foot got caught on the stair. Why did he lose his balance on the right side after his foot got caught on the stair? So notice when you do the 5 whys, you ask very specifically why the previous cause statement happened. So it's not just why, it's why did the previous thing happen? And this just helps frame people's thinking with how to answer the question. So the answer here is because he did not have support on his right side to help him balance. Why did he not have support on his right side to help him balance? Because there is not a handrail on the right side. There is only a left side handrail. Why is there only a left side handrail? Because that is the only bar that was ever installed. So here, the Acme team has arrived at a solution idea, which is to add a handrail to the right side, or if that's maybe not possible, ensure that he has right side support while going up the stairs. So this is this can be associated with the licensing requirement to identify solutions to mitigate the reoccurrence of future risk of harm when applicable. So that's 160E1C. And you can see taking action to address root causes, again, is related to regulation 160E. So as a reminder, the Office of Licensing has provided this resource also for you, the risk trigger and threshold and care concern handout. The location on the website is indicated on this slide. This handout includes the care concern criteria. So I'm gonna zoom in a little here. I'm being fancy today, my zooming in. So you can see John met the criteria for having multiple 2 or more unplanned medical hospital admissions or ER visits for falls, urinary tract infections, etc., because he had an ER visit for a fall and for seizures within 90 days. So this handout also outlines the provider's responsibilities, that they need to track on an ongoing basis their serious incidents and care concerns. So again, this is a handy one-pager that could help Acme or any provider kind of go, oh, was this a care concern? Here are the criteria, let's check. So because it is a care concern, Acme Residential needs to take a closer look at it and ask some questions. John met the criteria of 2 serious incidents in a 90-day period that are listed in that care concern criteria. So here are the questions listed on the slide that can help the provider review the care concern. Now these are the same questions. I got these from the flow chart that we have been using all along. They may not be the only questions you would ask, but they're suggested questions to explore. So they are there changes to the individual's needs, medical or behavioral concerns? Is the current care plan adequate? Is a more detailed root cause analysis needed? Per 160E2, has this happened to others? And is it a systemic issue? And then take action accordingly. Okay. So here, let's look at another tool. Acme has also used the Office of Licensing Serious Incident Review and Root Cause Analysis template. Hold on, guys. I need to take care of something. Literally 1 second. Okay, sorry about that. Had some background noise. All right, so you can see that I have filled it out, but I'm actually going to open it in the tool itself and show you what it looks like. Okay, so this is the template. And again, this is for our example. We have filled out the information at the top with the individual's name, date of birth, the location of the incident. And I was just going to show you, I know last time, some people said that they had trouble filling out these tools, like it wouldn't work for them to fill it out. One thing that I thought of was sometimes when you open these, you'll get this yellow bar at the top. I didn't get it this time, but sometimes I do. And it'll give you a little box where you have to enable editing. So make sure if you get that yellow box that you click on enable editing. Okay. Once you have clicked that and you're able to edit it, another thing that might be different than what you're used to is these kind of fill in the blank boxes. So you have to make sure to just click inside the box so you can add information like I just did. If you don't like the fill in the blanks, you can actually type outside of them if you want. It's basic, it's really up to you. Those are just created like for convenience. So we have all of this information, the details filled out at the top, and we have the sources of information or the interview with the individual and an interview with staff. That's how we got more information about what happened. Here we have that same description of what happened filled out on the form, the analysis of the incident. We indicated here that we use the 5 whys. And then here, I'm not going to read it to you, but I just basically summarized what our 5 whys found. And then it takes you to the second page with your recommended actions. So we recommended installing a support bar on the right side of the stairway, and Acme is planning to do that. That's the action plan within a month. And we have our threshold criteria outlined here. I didn't go into this, but I did kind of fill this out. And it does not meet the enhanced root cause analysis per their threshold criteria. But again, it was a care concern, so they reviewed it that way. And they had it, who completed it, the title, and the date. Okay, so just wanted to show you all that. All right. So finally, for this individual event, Acme Residential needs to add this incident to their data tracker. At the last session, we reviewed the new tool, the Excel Risk Tracker, and how to use it. This tool was sent to all participants. If you need to review it later, hopefully you've all taken a look at it. This was a level 2 fall that occurred in March. So the incident would be recorded in the cell indicated by the yellow highlight. So we had falls as the risk, and it was a level 2 in March. So we put a 1 right in there. It was also a care concern. So we also record it in the care concern tracker here. Multiple 2 or more ER visits in March. And so there must have been a 1 in here already. And so we changed it to 2 because now there are 2 that happened. Okay. Before we go on, actually, I'm going to quickly open the tracker and just show you how that would work in both trackers, just in case anybody had any quick questions about that. So like I just showed you this, that was the monthly tracker. So this is what the tracker would look like when you're using it. If we were to add, there's a lot of data in here already because this was my example one to create all the graphs we're going to be looking at. But if we were to add another fall, level 2 in March, we would add it right here, the fall in March, right in that cell. We would add it and it would make it a 2. If you're using the individual version of the tracker, you would go to the individual log and add an incident for John Harvey. And it was a fall. It was level 2. And then once you have done that for all 3 columns, it will then populate in your tracker right there, and add to your March total. And it would then populate the rest of the workbook as well. All right. So we've checked all of our responsibilities for the individual incident. So now let's do the quarterly review. So Acme has been entering data on risks and conditions all quarter using the Excel risk tracker. This is what their data shows in the monthly tracker and the care concern tracker. So this is what it looks like. They have data in every month. And it would total across the quarter in the second tab, in the next tab, the quarterly tab. And then for the care concerns, it totals it over here for the quarter. All right, so this to me is the fun part of looking at data. You look at the graphs. I'm a visual person. If you're like me, then you like graphs too. Here is their graph of all risks and conditions for all levels for quarter one. So you can tell it's quarter one, it's the dark green color. And so as we reviewed, the risks and conditions are along the bottom and the number are along the y-axis. So each bar represents the number of incidents. You can see that for quarter one, the highest number was falls at 11. And that was followed by UTIs at 9 incidents, and choking, there were 7 incidents. So this is the graph of just level 1 incidents for quarter one. The highest was medication errors at 6, followed by 5 UTIs and 3 level 1 incidents of dehydration. Okay, so I'm going to pose a rhetorical question. Do you think Acme Residential would have realized this pattern if they hadn't been collecting data in this way? It's probably a good question for all of these, right? How do you know what's really happening unless you're counting it? This is the graph for quarter one of level 2 incidents. The highest was 9. That was falls, followed by 3 each of aspiration pneumonia, choking, and seizure. And finally, this is the graph for care concerns. The highest was 7 care concerns for choking, 5 for decubitus ulcer or bowel obstruction, and 3 for multiple unplanned hospitalizations or ER visits. All right, so they've looked at their quarterly data and now they are doing their review. So for the quarterly review of serious incidents and care concerns, Acme decided to use the worksheet that is in the risk tracking tool. As you recall, it is the last tab in the tool, and this is what it looks like. So it's kind of a discussion guide to help discuss each of these categories or topics. So let's look at what they found. So let's look first at the risk conditions and serious incidents. Their summary was that for quarter one, there were 18 level 1 serious incidents and 38 level 2 serious incidents. There were no level 3 incidents. The highest number was for falls, then UTIs, and then choking. For level 1, medication errors were the highest, and for level 2, the highest were falls and UTIs. They were not able to look at trends yet because it was just the first quarter that they were doing this. For systemic issues or causes, they identified for falls that there were some walkway barriers, shelves, there were fall hazards, and the lack of a right side handrail at the entrance. So you'll notice that this brings in John Harvey's incident into their quarterly review. They discussed the individuals with UTIs have a history of risk and that there are protocols in place. And for the medication errors, the causes are unknown. Their remediation is that the fall hazards have been removed and a right side handrail has been ordered. For medication errors, a more detailed root cause analysis is needed. So to mitigate potential future incidents, they want to set a goal to reduce level 1 medication errors, and they will put this in their quality improvement plan. No other recommendations. For their care concerns, they found that there were 15 care concerns. Looking at trends, there were 3 care concerns for multiple hospital and ER admissions, 5 for decubitus ulcer and bowel obstruction, and 7 for choking. The potential systemic issues or causes. For choking and decubitus and bowel obstruction, all individuals who had an incident are at a known risk with protocols in place. But to remediate this, assigned staff will be retrained on individuals' protocols and choking prevention and intervention strategies, and individuals' protocols will be reviewed. Also, so that was specifically assigned staff, they are also going to train all staff on choking prevention and intervention strategies. No other recommendations at this time. So again, this is an example mainly born out of my brain. So if it has some issues, just be patient with me. It's mainly just for illustration purposes of how this would you would close the loop on everything that this provider has done. So finally, let's look at how Acme does their annual review. Here you can see that Acme has entered data in the risk tracking tool for the entire year. Look how beautiful that is. They have been entering data on risks and conditions each month, and also the care concerns and risk triggers and thresholds tracker. Let's look at their graphs. So here we're going to get a little interactive if we can. The graph shows the total risks and conditions at all levels for all quarters. So each bar is the quarter that it represents and the number of incidents for that risk. So I'm going to ask you all to put in the Q&A, how would you describe the patterns and trends here? So you could just pick one and tell me how you would describe it. I'm going to look in the Q&A to see if we have any volunteers. I'm not going to unmute anybody. I'm just going to read what people put in the Q&A. And there might be a little bit of a lag. I don't know necessarily how that works. All right. Thanks, guys. So falls are high. Falls seem to be very prevalent. A lot of incidents declined from the first to the third quarter. Okay. Falls are the highest occurring. Quarter 3 had a high level of incidents. Okay. Falls is a problem that needs urgent attention. UTIs and med errors. UTIs have gone up and stayed the same. All right, that's a great observation, as well as falls. I mean, somebody said that the risks have gone down. The only one that I see that has gone down is choking. Look at that. It really took a stair step down. All right, thanks for helping me out there. We're going to do that again with the next few. So you can look at this and start telling me how you would describe the trends and patterns. This is the graph of just level 1 serious incidents. Again, how would you describe the trends? Okay, UTIs have remained consistent, or like consistently, not a lot of change there. Way too many med errors. Yes. Med errors are not improving. In fact, they are staying the same at 8 each quarter. Great. Yeah, you noticed for quarters 2, 3, and 4, dehydration and falls also all stayed the same. Medication errors were definitely the highest there. All right, let's look at the next one here. Okay, somebody said we want to look into the link between dehydration and UTIs. Yes. So you're beginning to draw those connections like, okay, what could be the cause here? And are those two things related? I love that. Okay, let's look at the level 2 incidents for all quarters. Again, how would you describe the patterns and trends here? This one might be similar to the overall all levels, simply because there were a lot more of level 2, so it looks kind of similar to the first graph we looked at. I think the comments are coming in a little slowly. Not y'all's fault, I think it's Zoom, it's just the nature of the platform. All right, high level of falls, reduction in choking. Yep, so we're seeing, in addition to the care concerns, and remember, like choking single incidents are now, that require intervention are now care concerns. So we saw the decrease in care concerns. We're also seeing that same trend here. Falls and seizures are the highest. Then aspiration, pneumonia, there's some concern about that, has not improved. Okay. Dehydration and UTI is still a concern. Yeah. All right. Hopefully we're getting y'all's brains going on a Friday morning. Okay, we got one more. We're not going to talk about this one because there's only 2. There's only 2 level 3 incidents. There was 1 suicide attempt and 1 death at Acme Residential. And of course, you would have done a root cause analysis on those incidents. And here's our care concerns. This is our final graph, care concerns for the year. And let's see what trends stand out to you guys for this one. So the first one is the multiple to or planned ER hospital admissions, then decubitus ulcer, and then choking. Any choking that requires physical aid by another person. Okay. Okay, yep, care concerns made an impact on decreasing choking incidents. Choking has made improvements. Yep, looks like the choking training helped. Okay, so let's look finally at their annual review. So this is the end of the year after doing all of that hard work, and they filled it out. So for risks, conditions, and serious incidents for the year, they found that falls, UTIs, and med errors and dehydration had the highest number of incidents. For level 1, med errors was highest, then UTIs and dehydration. Falls were the highest level 2, then seizures, UTIs, and aspiration pneumonia. And there were 2 level 3 incidents. Their trends, they found that seizures and bowel obstruction increased in quarter 2 and quarter 3, and choking decreased after quarter 2. So their systemic issues or causes in quarter 2 and quarter 3, they did a root cause analysis of level 1 med errors and discovered the main cause was errors due to staff shortages. Their remediation was that they tried staff training on med errors, and the errors had become less serious in nature, but no change in the number of level 1 incidents. So to mitigate potential future incidents, they're going to keep working on this. They're going to identify additional changes they can make to reduce med errors in addition to their staff training. And they also recommend considering a project to reduce falls, seizures, and UTIs or UTIs. For risk triggers and thresholds, the highest care concern was choking, followed by 2 or more ER hospitalizations or ER visits, and the lowest was decubitus ulcer or bowel obstruction. They noted, like you guys did, good job, choking has decreased since improvement efforts were put in place, which happened in Q2, or at the end of Q1, really. There were no clear trends in the other measures. So for their systemic issues, the staff were trained in choking protocols and individuals' protocols were reviewed. ACME believes this helped reduce the rate of choking. They want to continue, however, to monitor choking rates for further improvement. No other mitigating steps or recommendations at this time. So now we're going to quickly look at how ACME uses their review of serious incidents and review of care concerns to complete the annual systemic risk assessment review. So this is just completing those sections of this template related to serious incidents and care concerns. So we filled out at the beginning the information about the organization, including the effective date. And under the section related to review of serious incidents, ACME decided that they liked the examples that were in there, and so they took example off, and they want to review all serious incidents and care concerns quarterly, and they're going to continue that, as well as reviewing all medication errors quarterly, whether they resulted in injury or not. And then they included, like they said they were going to, their level 1 medication errors and falls in their systemic risk assessment review. And they summarized what they found. I'm not going to read it because it's basically the same as what was in their summary, and their recommendations. And they added their goal here that they're going to put in their risk management plan. So their goal here is to reduce level 1 med errors by 30% during 2024 and add to the QI plan and risk management plan. They're going to do a more in-depth root cause analysis of falls. For risk triggers and thresholds, they added all their information also to this section, that they reviewed them quarterly and annually. The highest number was choking, etc. And the lowest was decubitus ulcer and bowel obstruction. And they're going to continue to monitor those quarterly and annually. They noted the decline in choking and that they'll monitor that. And they're going to add that to their risk management plan. All right, so this is just some reflection for you. You don't have to put it in the Q&A. You can just think about it for a moment. What do you think of ACME Residential's process of reviewing the individual event, doing the quarterly review, and the annual review? So hopefully you found this helpful. I know it was probably not perfect with an example. We'll try to come up with some other examples in the future. But how do you see this relating to your work? So just take a moment. Hopefully you thought about that throughout. And now I'm going to turn it over to Mackenzie Glasgow to give you some tips and reminders related to risk management and the root cause analysis policy.
Well, thank you, Mary Beth. I just want to say how great those examples were. I hope you all find them helpful as well. Very informative. So we appreciate that. Now we're going to review some data related to risk management and the root cause analysis policy, as well as provide you with tips and reminders. As a reminder, the provider shall designate a person responsible for the risk management function who has completed department approved training, which shall include training related to risk management, understanding of individual risk screening, conducting investigations, root cause analysis, and the use of data to identify risk patterns and trends. So the overall compliance rating for providers specific to 520A in 2022 was 77%. And we are looking, we would like to get to 86%, and we think it's something that, we can do. So the compliance results were related to several identified issues. Providers failed to complete the attestation. Some did not submit the job description for the person designated for the risk management function. Others did not complete the training that was listed on the crosswalk, and some did not sign the attestation. So now we're just going to provide you with a few tips and reminders. Please complete the required training for each topic area as outlined in the crosswalk of the approved risk management training. Indicate on the risk management attestation form the training the risk manager completed and include the date of completion. So there are some check boxes there for you and a place for the date. Only the DBHDS risk management attestation form can be used to demonstrate compliance. Training certificates from other organizations do not meet compliance for this regulation. Ensure the risk management attestation form is complete and that it is signed by the designated risk manager and their supervisor. Annual retraining is not required. Therefore, the attestation form does not need to be completed annually. However, a new attestation form must be completed when there is a change in the designated risk manager, as the new risk manager will be required to complete the approved risk management training. Also, attestations do not transfer from provider to provider. Lastly, please ensure that the job description for the risk manager includes risk management functions and responsibilities. All right, the risk management plan, the provider shall implement a written plan to identify, monitor, reduce, and minimize harms and risk of harm, including personal injury, infectious disease, property damage or loss, and other sources of potential liability. So the overall compliance rating specific to 520B in 2022 was 89%. So you all have reached that goal of 86%, but we need to continue to maintain this level of compliance. So providers who were compliant, they indicated how they would identify risks. They indicated how they would monitor risks, and they also indicated how they would reduce and minimize risks related to these areas outlined in 520B. Some tips and reminders. Make sure the risk management plan includes all of the components outlined in the regulation. Make sure it is a plan and not a policy. For risk management plans that are integrated with an overall quality improvement plan, the provider is expected to identify the sections that address the risk management requirements. The combined plan would need to be dated since the quality improvement plan is required to be updated at least annually. (520C), the provider shall conduct systemic risk assessment reviews at least annually to identify and respond to practices, situations, and policies that could result in the risk of harm to individuals receiving services. Some identified issues during inspections: either there was no systemic risk assessment, or the risk assessment that was provided had missing elements. You need to make sure that you address all 5 elements outlined in 520C 1 through 5, and care concerns as required per regulation 520D. Essentially, there are 6 elements that are required for the systemic risk assessment. Before we move on to tips and reminders, I want to remind everyone of the data that was shared during session 1 as it relates to provider compliance with the systemic risk assessment. So for 520C1 in 2022, providers were at 85% compliance. So we're really close to that 86% mark as it relates to addressing the environment of care. 520C2, providers were at 81% compliance. So some more work needs to be done as it relates to addressing risks associated with clinical assessment and reassessment processes. 520C3, providers were at 80% compliance. with more work needed related to addressing staff competence and adequacy of staffing. 520C4, providers were at 79% compliance with more work needed as it relates to addressing use of high-risk procedures, including seclusion and restraint. 520C5, providers were at 85% compliance. Again, so close to our goal of 86% as it relates to addressing risks related to serious incidents. So it's a good thing you guys have attended this training. We think you have the tools that you need to get to where we need to be. Next slide. All right, some tips and reminders related to the systemic risk assessment as well as care concerns. So the objective is to provide, and this is related to the environment of care, the objective is to provide a safe, functional, and effective environment for individuals served, staff members, and others. Safety inspections. Results of safety inspections should be incorporated into the systemic risk assessment. Some providers have presented the safety inspection as the systemic risk assessment related to the environment of care. The environmental risk assessment should include the results of the annual safety inspection where applicable, but it is much broader than a safety inspection. Organizations will have different risks associated with its environment of care, and providers need to think about their environment of care and the potential risks. Conduct an examination of what internal and external factors or situations could cause harm to the individual served, or that could negatively impact the organization. And don't forget to use the optional template, it is optional, which is the annual systemic risk assessment template developed by DBHDS. All right, a few tips and reminders related to clinical assessment and reassessment processes. So examples of assessments include physical exams that are completed prior to admission or anytime there's a change in the individual's physical or mental condition. Reassessments, this could be reviews of incidents in which the individual was involved, reviews of the individual's health risks. Remember, the person designated as responsible for the risk management function does not need to be engaged in the clinical assessment or reassessment process, but should review these processes during the risk assessment review. Got a few other examples to think about. Admission assessments include risk of harm to self or others. Physical exams for individuals are completed annually. Assessments and reassessments include a fall risk assessment. Reassessments include a review of incidents in which the individual was involved. And don't forget, we've got that optional template that you all can use for the annual systemic risk assessment. Tips and reminders related to staff competence and adequacy of staffing. Staff competency and adequacy of staffing must both be addressed in the systemic risk assessment review. As part of the annual systemic risk assessment, the provider might ask such questions. Do all employees meet the minimum qualifications to perform their duties? Have the employees' contractors receive the necessary training to enable them to support the individuals receiving services and to carry out their job responsibilities? What was the staff turnover rate? What issues impacted the staffing plan over the past year? And don't forget about that annual systemic risk assessment template. If you don't have a systemic risk assessment, get started. All right, let's talk about some tips and reminders related to high-risk procedures, including seclusion and restraint. Consider what high-risk procedures are being used. Do we use seclusion and restraint? Do we administer high-risk medications? How do we transfer individuals who are non-ambulatory? Just to name a few, but there are so many more. Based on a provider's high-risk procedures, providers should ask the following. Are we following applicable laws and regulations that govern their use? Are we reviewing procedures to determine whether they are still appropriate? Are staff who are implementing high-risk procedures qualified to do so? Is the use of seclusion and restraint in compliance with human rights regulations? Again, we also have that optional template for your use. All right, some tips and reminders related to reviewing serious incidents. Providers should have a policy that defines who has the authority and responsibility to act when a serious incident or a pattern of serious incidents indicates that an individual is at risk. Reviewing incidents quarterly. Mary Beth touched on this earlier. In accordance with 160C, all serious incidents, including level 1, level 2, and level 3, are to be reviewed at least quarterly to analyze for trends, potential systemic issues or causes, indicated remediation, and documentation of steps taken to mitigate the potential for future incidents. Annually, conduct a systemic risk assessment and include all data from serious incidents. Year-over-year trends. The provider must have evidence that they completed an analysis. The provider must have evidence that they completed an analysis of trends from their quarterly review of serious incidents, identified potential systemic issues or causes, indicated remediation, and planned implemented steps taken to mitigate the potential for future incidents. This includes identifying year-over-year trends and patterns and the use of baseline data to assess the effectiveness of risk management systems. Common risks and conditions. A provider's systemic risk assessment should identify the incidences of common risks and conditions that occurred. Developmental disability providers would focus on incidences of common risks for individuals served. And again, we have the template for your use. All right, don't forget that DBHDS defines risk triggers and thresholds as care concerns through review of serious incident reporting conducted by the Incident Management Unit. In 2022, providers were at 79% compliance. The Incident Management Unit reviews serious incidents not only on an individual level, but systematically as well to identify possible patterns, trends by individuals, a provider's licensed service, and across providers. Through this review, the Incident Management Unit is able to identify areas based on serious incidents where there's potential risk for more serious future outcomes. When care concern thresholds are met, it may be an indication a provider may need to reevaluate an individual's needs and supports, review the results of their root cause analysis, or even consider making more systemic changes. Tips and reminders related to care concerns. Providers who had care concerns must indicate in their systemic risk assessment how they address the care concerns in their risk management process. If the provider has not had any care concerns, the systemic risk assessment review should outline how they would address care concerns if they were to occur. Again, we have the optional template as well as the risk tracking tool that Mary Beth shared with you during last week's session and again today. Reminders related to safety inspections. Just remember, a review of the environment of care should consider the results of the annual safety inspections when applicable, but it is broader than a safety inspection. The environment of care is not the safety inspection, but it may include the results of safety inspections. I know a few people had questions about that throughout the training, so we wanted to provide additional clarification. As you can see, providers were at 90% compliance as it relates to safety inspections, so keep up the great work there. Now we're going to switch gears and provide some tips and reminders related to the root cause analysis policy. Remember, all providers are required to develop and implement a root cause analysis policy for determining when a more detailed root cause analysis should be conducted. This includes convening a team, collecting and analyzing data, mapping processes, and charting causal factors. At a minimum, the policy must indicate when the provider will complete a more detailed root cause analysis. So I do want to repeat again what a more detailed root cause analysis means. This includes convening a team, collecting and analyzing data, mapping processes, and charting causal factors. The root cause analysis policy could also outline who will appoint a team if a more detailed RCA is being conducted. Keep in mind that your root cause analysis policy can be part of your serious incident reporting policy. So let's review compliance for the policy, the root cause analysis policy. So providers have made significant progress over the past few years as it relates to the root cause analysis policy. In 2022, providers were at 83% compliance. As it relates to 160E2A, that is one where the provider has to determine their threshold number. Providers were at 86% compliance as it relates to 160E2B. That regulation, the threshold number is already determined by the regulation. Providers were at 81% compliance as it relates to 160E2C. Again, that is one where the provider determines the threshold number. And 160E2D, providers were at 90% compliance. I'm sorry, providers were at 89% compliance. All right, so we're going to move on to the tips and reminders related to the root cause analysis policy. When developing the root cause analysis policy, providers should take into consideration the number of locations, the number of individuals receiving services, the type of services the provider provides, and the unique needs of the individuals. The term threshold, as it relates to the regulations, mandates that the provider must establish a criteria by setting an amount or number that, if met, will require them to conduct a more detailed root cause analysis. Remember, regulations 160E2A and 160E2C both require the provider to determine a threshold number. 160E2B and 160E2D, the regulations include the minimum regulatory requirement for the policy. Once a threshold has been met, then the provider is responsible for conducting a more detailed root cause analysis of the incidents that resulted in meeting the threshold. Again, a more detailed root cause analysis includes convening a team, collecting and analyzing data, mapping processes, and charting causal factors. We also provided you with the serious incident review and root cause analysis template last week. Don't forget, this is an internal reporting tool for serious incidents. It's a tool for completing a root cause analysis, and the tool can be used to determine if a more detailed root cause analysis is needed. So utilizing this template will assist providers in achieving compliance with the regulatory requirements. All right. So the last thing I want to just share with you is this visual. So this is a reminder that there is a relationship to a central idea, which is to improve the provider's processes and outcomes for individuals served. The ring of circles contributes to the central idea. So as you see in the middle, processes and outcomes, and we've got this ring on the outside. We've talked about the systemic risk assessment. We've talked about the risk management plan. We've talked about root cause analysis, and we've also touched on the quality improvement plan. So now I'm going to turn it over to Larissa, who is going to address some of the frequently asked questions.
Thank you, Mackenzie. Good morning, everyone. Now we're going to take a few minutes to address some frequently asked questions. These questions were asked by providers just like you, so we hope they're helpful. All right, our first question is, sometimes multiple unplanned hospital visits occur because the hospitals prematurely discharge despite our advocacy. Then, if the individual continues to need medical attention and we take them back to appropriately seek care, we might be dinged for doing exactly what we should be doing. We sometimes seem to be answering for the hospital's lack of appropriate care. How should care concerns be addressed in this situation? Our answer for you all on this topic is, when care concern thresholds are met, it may be an indication that a provider could benefit from reevaluating an individual's needs and supports, reviewing the results of their root cause analysis, or even making more systemic changes. However, the Office of Licensing realizes that providers who support individuals with higher needs may have higher number of incidents. Therefore, just because an incident meets a care concern threshold does not mean that a provider is not doing what they're supposed to be doing or that the Office of Licensing has concerns. Keep in mind that serious incident reports are not punitive. Here we see another question that we are frequently asked. Do you need a nurse on staff to conduct risk management activities? The answer. In accordance with Regulation 520A, the provider shall designate a person responsible for the risk management function who has completed department-approved training. Training shall include risk management, understanding of individual risk screening, conducting investigations, root cause analysis, and the use of data to identify risk patterns and trends. This person responsible for the risk management function is required to complete the DBHDS approved risk management training updated crosswalk of DBHDS approved attestation trainings. Additionally, the person responsible for risk management shall attest to the completion of the required training by signing and dating the DBHDS risk management attestation form. The attestations shall also be signed and dated by the person's direct supervisor if applicable. The attestation form does not need to be submitted directly to the Office of Licensing upon completion. However, the form must be kept on file and presented upon request by the Office of Licensing during both on-site and remote inspections. Moving along to the next question. How often does the systemic risk assessment need to be completed? Our answer: the provider shall conduct systemic risk assessment reviews at least annually to identify and respond to practices, situations, and policies that could result in the risk of harm to individuals receiving services. Remember that the risk assessment review shall address at least the following: the environment of care, clinical assessment or reassessment processes, staff competence and adequacy of staffing, use of high-risk procedures, including seclusion and restraint, and a review of serious incidents. This question pertains to how the regulations apply to different types of providers. The question is, what are the differences required per provider when it comes to systemic risk assessment? For instance, an in-home provider versus a group home service. It would be helpful if the department could break it down so different providers can understand more specifically what applies to their setting. And our answer: this is important. All regulations apply to all licensed services unless specifically stated otherwise. An assessment of the environment of care for community-based services should include an analysis of the risks associated with the provision of services in the community and any risks unique to the community locations where services are expected to be provided. While providers may not have direct control over these risks, analysis of them will help the provider develop a plan to mitigate those risks. For suggestions on what to include in your systemic risk assessment, please review the Guidance for Risk Management and the training documents located on the Office of Licensing website. Here we have another great question. What is considered a high-risk medication in terms of an example used in the systemic risk assessment? And our answer: a high-risk medication is a medication that carries a greater than typical risk of serious side effects or other complications. When conducting a risk assessment, a provider shall consider the use of high-risk procedures. More information on systemic risk assessment can be found in the Guidance for Risk Management and the training documents located on the Office of Licensing website. Now, this is a question that some of you may be wondering about today. The question is, if providers have already completed their systemic risk assessment and updated their risk management plan before this training, is the expectation that providers will update it again before their annual assessment? A provider only needs to update their systemic risk assessment and risk management plan if the provider was non-compliant during last year's inspection, or after completion of this webinar, the provider determines themselves that they are not in compliance with the regulations. This is a helpful clarification question. The question is, can you briefly explain key differences between risk management plan and quality improvement plan? The answer. A quality improvement plan is a detailed work plan developed by a provider that defines steps the provider will take to review the quality of services it provides and to manage initiatives to improve quality. A quality improvement plan consists of systemic and continuous actions that lead to measurable improvement in the services, supports, and health status of the individuals receiving services. A quality improvement plan includes measurable goals and objectives, as well as progress towards meeting those goals. A written risk management plan focuses on identifying, monitoring, reducing, and minimizing harms and risk of harm through a continuous, comprehensive approach. The risk management plan should include identifying year-to-year trends and patterns and the use of baseline data to assess the effectiveness of risk management systems. And another helpful question. Is the root cause analysis supposed to be done monthly, every quarter, or yearly? Their answer. A root cause analysis shall be conducted by the provider within 30 days of discovery of level 2 serious incidents and any level 3 serious incidents that occur during the provision of a service or on the provider's premises. The provider shall also develop and implement a root cause analysis policy for determining when a more detailed root cause analysis should be conducted. Root cause analysis shall also be conducted as part of a provider's quality improvement or risk management program, as RCA is considered a standard quality improvement tool to identify the underlying causes of a problem. The focus of a root cause analysis is on systems, processes, and outcomes that require change to reduce the risk of harm. This question is valuable for providers who might be seeking feedback from the department. The question is, how do providers receive feedback related to their policies and procedures? It may be helpful if providers knew especially what their identified issues are as it applies to the regulations. It's important for you to know that providers may reach out to their licensing specialist to seek feedback related to their policies and procedures. If a provider is cited during an inspection, an exit interview should occur, which provides an opportunity to discuss areas of noncompliance as well as recommendations for coming into compliance with the regulations. Now I'm going to turn it back over to Mary Beth, who is going to review how to take it further by creating measurable goals and objectives.
All right, thank you, Larissa. So hopefully that cleared up some questions that participants may have had. That was a great Q&A session, Larissa, thank you. Now let's look at the end of the flow chart, which I like to think about how to take it further. So we're going to talk about just a few ways to do that. So in the flow chart, what it asks is, do any actions need to be taken to address these risks? So I know you all have been on this journey with me through the individual risk identification and reporting process, the quarterly review, and the annual systemic risk assessment review. So we're at the point of, you probably have taken actions along the way, but when you get to the annual portion, do any actions need to be taken? Do you need to review and update any policies? Should any of these risks be incorporated into your risk management or quality improvement plan? And of course, if you answer yes, you would take those identified actions. And if no, and also if yes, you would continue the incident review cycle of activities. So let's look a little closer about how you might take it further, particularly with these regulations. Okay. So one way to take it further is to use everything you've learned through your serious incident reviews to create measurable goals and objectives. This is a requirement outlined in Regulation 620C2. Here is an example. We're going to return to Acme Residential. They used the criteria for creating a goal and objective of making it SMART. So hopefully you've all heard about SMART, but if not, it stands for an objective or goal that is specific, measurable, achievable, relevant, and time-bound. So the way that Acme has written their first measurable goal is by December 31st, 2024, Acme Residential wants to reduce the number of level 1 medication errors by 30%. The baseline during 2023 was 30 medication errors. The goal is 21 medication errors or fewer. They will incorporate this into their quality improvement plan, which is per Regulation 620B. And they will also incorporate strategies to reduce medication errors into their risk management plan, 520B. So I'm going to just focus in a little bit because I have time to do this. So what makes this goal SMART exactly? So first of all, it is specific because we know it is talking specifically about medication errors. They're not just talking generally about serious incidents. You're able to understand what they are specifically wanting to reduce. It is measurable because they have included baseline data and their goal in terms of a % reduction. And they've even told you what their baseline number was and their goal number was, which is with the 30% reduction. Hopefully they have met as a team and decided that this was achievable for them, meaning that they could realistically see themselves being able to do this by the timeline. And of course, you want it to be relevant to the work that you do every day. So this is relevant, of course, to their work. Medication errors are something that they need to review quarterly and, of course, can present a serious risk to individuals. And so it is very relevant to their work. And we already talked about that it is time-bound because it has a goal date. And they've given themselves quite a bit of time to achieve this. And they're going to be monitoring this along the way, which they would also include in their quality improvement plan, how they were going to monitor this. Ways that they could monitor this would be meeting as a team every month to look at the number of medication errors and doing that calculation and reviewing their improvement strategies. So let's look at another measurable goal that they have established. Again, they're using the SMART criteria, and they say by December 31st, 2024, Acme Residential wants to reduce the number of care concerns due to choking to 0. So they have a 0 goal here. The baseline during 2023 was 7 choking care concerns. So you'll notice that they have one goal related to medication errors, serious incident, and then they have a goal related to care concerns. Again, they will incorporate this into their quality improvement plan and put their reduction strategies for choking care concerns into their risk management plan. All right, so we just talked about how they want to incorporate this information into their quality improvement plan and risk management plans, all based on what they found in their risk reviews. So while we aren't going into depth in this training about risk management plans and quality improvement plans, I want to point out that the Office of Licensing has very helpful examples of these plans on the website. So here's the link for each one. There is a sample, you'll see it's in the title here, the sample for the provider risk management plan and a sample for the provider quality improvement plan. So I'm just going to click on those so you can see what they look like and scroll through them. So if you're, like, I don't know what to, how to create a risk management plan, or I'm not sure if I have all the right components for a risk management plan, this sample will really help you determine that. And I will say, you have to read it closely, right? So it tells you this is a sample. It has all of the information that you need in order to work on your risk management plan. So it has each regulation or sub-regulation, for example, and it has an example of how you would put this in a risk management plan. Okay. So I know we hadn't pointed this out earlier in the training, but I definitely wanted to make sure that you knew about it. So this is the risk management one. Let me open the quality improvement one. So again, it explains all of the regulations and regulatory requirements. And the sample starts here where it says sample quality improvement plan. It tells you for each sub-regulation what is needed and gives you some tips for best practices. I love the idea of having a table of contents. Oh, it's not scrolling for me. That's not good. All right, there it goes. Hopefully things don't freeze up right now. So just, if you have questions about either one of those things, I would definitely refer you to these resources. And I wanted to share that the Office of Licensing will be releasing new templates to assist with these functions as well in June of this year. So I know the Office of Licensing has introduced several templates as part of this training. And so I imagine they'll be equally, if not more helpful when the templates are released for risk management plan and quality improvement plan. So make sure you look out for those. Again, they should be around June of this year. So this is actually another reminder or plug to make sure you are signed up for the Office of Licensing listserv so you get any announcements about things like templates. Okay, so now let's look at our incident review flowchart, our map, our guide, one last time. Now that we have talked about a few ideas about how to take it further, we have gone through all of the elements in this map. We have taken the whole journey together. We truly hope that as we've gone through this journey, you've learned about valuable information and tools that can get you closer to achieving compliance with 520C, 520D, 160C, or any of the other regulations that have been reviewed. We truly want you to be successful, and I'm going to echo what Britt said at the beginning. We know you can do it. So I think maybe as a surprise to all of us, we are almost at the end of today's session. Looks like we're going to be ending early. So this is the end of today's session and the end of the 3-part training. Can you believe it? Hopefully, many of you that have attended all 3 days, hopefully many of you have attended all 3 days with us. And if so, we want to thank you very much for giving that much time, spending that much time with us. If you attended 1 or 2, we also want to thank you. As a reminder, frequently asked question document, along with the slides and handouts and the recording, will be made available after the training. And last but not least, we have one last post-test for you. We want you to please take the time to do the post-test. So I'm going to put the link to the post-test in the chat right now. I'm gonna have to stop. I'm gonna have to close my slides for a moment to do that. But it worked well last time. So hopefully it'll work this time to send a chat to everyone. All right. So I just put it in the chat and I just clicked on it, so it does work. This is what it looks like when you open it up. And this is the very last post test that you'll be doing for us for this training at least. Let me put the slides back up. So since we are ending early, you have plenty of time to do the post test right now. In addition, the link will be emailed to you after the training. But it's probably best if you can do it while it's fresh on your mind. We will be keeping the post-test link up until Tuesday, May 2nd at noon. And truly, it is important for us to hear from you. We need to know what you got out of the training, and that helps us know what we can improve. I want to tell you that the next few slides have some resource information on them, so that when you do get the slides, you'll have all of those resources with the live links. And I guess before we conclude the training, I want to ask if any of my fellow panelists have anything to say here at the conclusion of our 3-day training. So Britt or Mackenzie or Larissa?
Yeah, I just want to thank everybody. It is a lot of time that you've devoted to going through the 3 days of training. We appreciate that greatly. And, I feel like you've gotten possibly a lot of questions answered that maybe you had before, and some clarification. And that was really our goal, and that to give you some tools and resources that you can use and use effectively. So thank y'all again for your participation. Please give us your feedback. Please take those tests, because that helps us know what we need to do to get better. So thank y'all.
Thank you, Britt. Anybody else?
Yes, Mary Beth, I just wanted to thank everyone for attending. We provided a lot of information in a very short period of time, so we hope you all found it helpful. We will be posting, I know that's the #1 question, when will the webinar and when will the slides be posted? We're hoping to get those posted within the next week or so, and all of the answers to the frequently asked, or all of the questions answered, so that we can provide you all with an FAQ that goes along with the webinar. So it just takes a little bit of time to get all of those questions answered, so that we can get that out to you all. So we appreciate your patience, and once these items are ready to be posted on the website, if you are signed up for Constant Contact, you will receive a notification. So thank you again.
Great. Thanks, Mackenzie. All right, I think we're gonna leave. I'm gonna wait just a minute or two, make sure people's questions come in. We want to make sure all the questions are captured. I'm actually gonna go ahead and stop the recording.